managing committee, I would like to introduce to you to our speaker, Dr. Kasturi Bhadsavade. Actually, Dr. Kasturi doesn't need an introduction as such. But I'll just briefly go through her introduction. So Dr. Kasturi is graduated and post-graduated from prestigious Bombay Veterinary College in the year 2004 and 2006. She did her master's in Department of Surgery, and her topic of research was cataract surgery in dogs. And due to her interest in ophthalmology, she pursued her interest in countries like Israel, Australia, and America. Dr. Kasturi is the founder of the iVet clinics in Bombay, in Mumbai and Pune, which is the first exclusive veterinary clinic, ophthalmic veterinary clinic in India. Her topic of discussion, or her session is today's session. The topic of session today is ophthalmic emergencies, and I'm sure in your clinic each one of you have had a case, which had to be dealt with an ophthalmic emergencies. So I hope this lecture is this lecture is going to be helpful for you for the future, in your future practice. Over to you, Dr. Kasturi. Thank you.
Thank you so much, Dr. Smita. This is a wonderful opportunity, and to get to talk in front of you all. I hope the session is useful for you in your practice. So the today's topic, let me just share my screen. Okay, can everyone see my screen? Is that, and am I audible?
Yes, yes.
Yes,
Okay, so today's topic is ocular emergencies. In order to go directly to the before we go directly to the ocular emergencies, I would like to just orient everyone in terms of ocular anatomy, mainly because I know that there are students who are attending the lecture today as well. Basically, an eyeball is like fluid filled squishy globe. It is protected in our skull, and with the orbit, okay, bony orbit. Now, if you look at the anatomical structure of the eyeball, the clear cornea or the transparent cornea, and the fibrous sclera forms the shell of the eyeball. Okay, as you go inside, this portion is called as aqueous humor, or the anterior chamber is filled with aqueous fluid. Now this aqueous fluid is generated in a gland over here. Okay, this gland is called a ciliary body. Now, ciliary body is constantly generating aqueous, and the aqueous is basically gets circulated in the anterior chamber, and then it gets filtered out through an angle here. This angle is called as iridocorneal angle. Okay, so there is a constant generation of the fluid, and then it gets it gets out from the iridocorneal angle. Then if you see this portion, it's called as iris. Okay, and this portion in the center, basically lack of iris, this in the center is called as pupil. Iris is a highly vascular structure. Okay, and it is also a muscular structure. So it has skeletal muscles. Sorry, not skeletal muscles. So it is a muscular structure, and it's a highly vascular structure. Okay, as it responds to light. So if there is if you get light in the eye, the iris constricts, which means basically the pupil constricts, and in dark the pupil dilates so that the more light can get in. Now this highly vascular structure is a part of uvea. Okay, uvea means all the vascular structures of the eye. Now iris, ciliary body, and this red structure here at the back called as choroid. Okay, these structures, all these three structures combined, they're called as combined is called as uvea. The front portion, the iris and the ciliary body form anterior uvea, and then the choroid at the back is called as posterior uvea. Now behind the iris is a crystalline lens. This crystalline lens is suspended in the center, right in the middle, with the help of these zonules. Now these zonules are like tiny little strings. These tiny little strings are attached to the ciliary body. Behind the lens is a gel-like structure. It's transparent gel-like structure, is called as vitreous. Now, vitreous doesn't have any cells. Any of these transparent structures have very little cells. Okay, the the reason that they have very little cells is because the less cells mean transparency. Okay, more cells meaning lack of transparency. So the vitreous, the lens, aqueous humor, and the cornea have very little cells, and they are absolutely transparent so that the light from outside can fall onto the retina. Now the retina sits right here at the back, and then all the axons come together and they form an optic nerve. Okay, so this is a structure of the eyeball. Now, if we go, we'll start with our ocular emergencies. Blunt trauma. So blunt trauma, in my opinion, is worse than a sharp injury, because whenever, so if you get if you get an animal, or if you get a dog who's being hit by a ball in its eye, because sometimes you play fetch or play catch with your ball, with the animals or with dogs, and if that ball hits them in the eye, or sometimes a horse, while running, they can bump into an object, and they can get a blunt trauma. Now the reason that the blunt trauma is more dangerous than a sharp injury is because sharp injury can just go in and come out. A little bit of fluid can gush out, and that's it. And a fibrin plug can plug that. But a blunt trauma, because the eyeball is a squishy structure and it is all connected, a blunt trauma can actually form an excessive amount of force, which can actually rupture the eyeball at its weakest position, weakest point. And this weakest point is usually at the limbus. Okay, limbus is basically where the transparent cornea and the sclera, they join together. Okay, so the eyeball can rupture. Sometimes there is a bleeding at the back of the eye. Sometimes there's a retinal detachment. Okay, in some cases I've also seen the lens can luxate as well. Okay, in whenever why is it important to know this is, when you know this, you would look for it. Because if you see if an animal is brought to you for a blunt injury, you would check the eye. It's not ruptured, and you might just let it go. It might not look as horrible. Okay, but you need to do an ocular ultrasound in these cases. And as I have discussed about uvea, for the choroid, if there is a bleeding at the back, for the drugs to reach at the back of the eye, you need to treat them systemically. You cannot start putting the drops in and expect everything to go away. So you need to start treating them systemically as well. You need to give them, whenever there is a uveitis, or whenever there is intraocular inflammation, the blood ocular barrier is breached, and an infection can get in. Okay, so you need to treat them with systemic antibiotic. You need to treat them with systemic anti-inflammatory. You need to look for a corneal ulcer in these cases. You also need to look for a rupture. Okay, sometimes the rupture is not very visible, and you need to sometimes sedate or anesthetize the animal, sometimes put local anesthetic and look for a rupture. Okay, all this so that you can give a prognosis to the owners. What I usually check also is, I check for an indirect pupillary light reflex in case the eye is filled with blood. So indirect PLR is checked by when you put bright light in the affected eye. If the other side pupil is constricting, that means this eye is still functional. Okay, and more than functional, this eye still has a chance that we can, we can try and save this eye, the vision. All this so that you can inform the owner properly. Now, penetrating foreign body. If you get a dog like this, that's very unfortunate dog, but I mean, this can happen. But if you see this, if you see something like this, please avoid the urge to just go in and pulling that thorn out. Okay, do not go in and pull the thorn out, because the first thing that's going to happen when you pull the thorn out is the aqueous is going to start gushing out, and you wouldn't know what to do. Okay, so you need to be prepared. Whenever you get a case like this, you need to be absolutely prepared of all the things that are going to happen next. Okay, the other thing that can go wrong in this is the thorn can break in the middle, and it can the half of the half broken part of the thorn can just stay in the aqueous chamber, okay, and anterior chamber, and that would be a disaster to deal with. Whenever a plant material enters the eye, okay, there's a very high chance that that plant material took along with it some fungus or some bacteria which is not supposed to be inside the eye. So you should be prepared for all these things. Okay, and the way it is described and the way I do manage these things is anesthetize them, clean the eye thoroughly out from outside, and then with a 10-0 needle. Okay, the reason the 10-0 needle, 10-0 sutures needle, the needle that is attached to the 10-0 suture material, you use that, you go from the side. Okay, so you enter the cornea from the side, not from here, from the side, and slowly and steadily you nudge, you slowly and steadily nudge the foreign material out. Okay, so you just have to be very patient, and slowly and steadily you need to pull that out, and be prepared to lavage this eye with antibiotic. There are some intraocular antibiotics that you can use you can put them in the lavage, and you can lavage the eye. And then you will have to suture this, because this is a big thorn that is, there's a big hole there. So it just needs 110-0 or 90 or even 80 suture can fix this hole. Cat scratch or corneal laceration. Okay, so cats love to, I mean, cat fights don't last that long. They just go wham, and then we feel that most of the times most of the animals don't manage to do as much damage to each other than most of the cats can manage in 1 second. Okay, that 1 second fight can cause this. Okay, they can actually go in, their claws are as sharp as surgical blades. They act like surgical blades. I've seen cases where there was a cat scratch wound, more than a scratch, there was a penetrating cornea, penetrating cat scratch. And by the time the owners brought the cat to us, within 24 hours the external wound had completely healed. There was no sign there was no stain uptake, there was no sign of an injury. But the cat had severe uveitis. Okay, so if you get a case like this, it's very clear cut rupture and clear cut laceration. And in these cases, basically you just need to what we do is we cut the prolapsed iris, and we lavage the eye with antibiotic and suture this, and then we prepare for a severe uveitis that is going to follow after we suture this cornea. So how do we prepare for that? Is we start them on high doses of antibiotics, different combination of antibiotics. I love doxycycline. Doxycycline is my go-to antibiotic, systemic antibiotic. In these cases, I would also start them on clindamycin and systemic anti-inflammatory agents. If it's if the liver values and everything else is okay, then I would even start this cat on systemic steroid. just to control or just to manage the uveitis. Um, so yeah, so lavaging the anterior chamber and getting in early and cleaning this anterior chamber as soon as possible is important. Whenever there is a ruptured cornea or whenever there is a ruptured eyeball, you should always think that there is a possibility of of retinal detachment. So again, as I discussed before, you should always, if you have an ocular ultrasound, or if you have an ultrasound, just ultrasound the eye when the animal is sedated or anesthetized. Um, or you can check for consensual PLR or dazzle reflex. Okay, sometimes these cases, this animal had menace positive. This animal, this cat had vision when we saw the cat, and we sutured the cornea. And usually cat wounds or cat corneal suturing, they do absolutely brilliantly well. They heal beautifully. And expect the same thing in dogs as well. If you have if you get get an animal with who's closing his eye, and there is a unknown injury to the eye, you should always ask the owners whether you have a cat, or whether the dog has a any contact with any cats, because cats can be evil sometimes. Okay, proptosis of the eyeball. This is something that everyone, all the general practitioners, all the emergency clinics, they have to deal with this, and it's a very, very common condition these days, because we all are in the cities, in the metro cities, because of lack of space now, all the toy breeds or brachycephalic breeds are quite common. And because they have a very shallow orbit, with a little bit of pressure on their neck. Okay, with by just if on even if sometimes they can, if they're too scared or too excited, if they fall from somewhere, they can they can actually have a proptosis of the eyeball. The eyeball can pop out. Now when the eyeball pops out like this, it's fairly, most of the times it's okay. But whenever you see a case of a proptosis of the eyeball, you need to imagine the anatomy of the eye. Okay, so there are 7 extraocular muscles, and then there is an optic nerve at the back. Now if by any chance, okay, the eyeball has popped out with so much pressure, that if one of the extraocular muscles have been cut, okay, or have been avulsed, if the optic nerve is severed, or if the optic nerve gets cut, then if the I mean then the prognosis of this of the eyeball is very, very poor. Okay, if all the extraocular muscles are intact, okay, then you can probably save the globe. Okay, so if all the extraocular muscles are intact, but the animal has no menace, there is no dazzle reflex, there is no consensual pupillary light reflex, then in those cases there's very little chance that the animal will develop vision afterwards. Okay, if any of the muscles are damaged, like in this dog, I mean this is like a extreme case, but most of the times if the medial rectus muscle is broken, then the eyeball is kind of it shifts, and you can see a significant shift of the cornea. um, and most of the times in those cases you can actually see a place where the muscle has been broken. And in those cases, the prognosis of even maintaining the globe is very poor. Okay, the reason being that the eyeball doesn't only shift its position, it also remains even after you've replaced the eyeball, even after you have done a tarsorrhaphy for 10 days. After you open it up, most of the times, most of these cases, the eyeball still remains quite prominent, and is always very prone to getting corneal ulcers. Okay, So all this so that you can, again, you have to give prognosis to the owners, because most of the times the owners think that, the eyeball has gone in, you have stitched it up, it's going to be absolutely fine. So the owners need to have the idea, they need to know what to expect later. And when you start preparing them from the beginning, 10 days before you actually open the stitches, then they're prepared for any kind of any, expect anything. The other thing is, sometimes the owners just want one surgery for their patient, and they just for their pet. And if you tell them that, there is a very high chance that, this dog has lost his vision in this eye, and we may actually need to remove that eyeball later, just because one of the muscles, or one or two of those muscles are broken. And in that case, they would, in some owners might want just one surgery and get the eyeball removed. So yeah, so basically stabilize the patient. So whenever you see this case, stabilize the patient. The patient usually is very, kind of in pain. Sometimes they're aggressive because of the pain. So give them pain relief, stabilize the patient, stabilize the owners, because the owners are, even more, freaking out. um, so once you have stabilized the patient, you need to check the PLR, it's consensual pupillary light reflex. So in this dog, in this eye, I would check the consensual pupillary light reflex. If there is a good pupillary light reflex, then that's perfect. The dog will never blink in this eye, okay, because the eyelids are not movable, okay. So don't try and check for menace reflex or dazzle reflex in these cases. Basically, what you're looking for is consensual pupillary light reflex. So shine light in this eye and check for a movement, okay, in the pupillary movement in the other eye. Okay, so you basically get your assistant or someone to look at the other eye while you shine the light in this eye. Okay, so because if you are using a torch, you're putting the torch in this eye, and then just to check for a consensual pupillary light reflex, if you shine the light in the other side, that eye will constrict anyways, because of the direct pupillary light reflex. So check for any foreign objects, check if there are anything sharp which is still, causing any damage. um, and discuss the possibilities with the owners. Okay, discuss that there is a possibility that this there's a good chance that this dog will see in this eye, because there is a consensual pupillary light reflex, or there is a very good chance that this dog may not be able to see, but we may be able to save the globe. Or the third option is that, there is a quite significant possibility that we may have to remove this eyeball, even after we, do the tarsography. Okay, so how do you fix it? Uh, Please don't try to save the anesthesia for these patients. They need to be anesthetized. Do not try to shove the eyeball in. Okay, do not forcefully push the eyeball in. That's not how you fix this. Okay, even though you have done that previously and the dogs have done well, please stop that practice, because that's not how you do it. There's a very, very easy and simple way to do it. So you need to give a general anesthesia to the patient, clean the eyeball. You can even shave the hair, so that you can see properly, because in Shih Tzus, or in Pekingese, there's so much hair that you can barely see what is going on with the, around the eye. So shave, clean. I usually use tear-free baby shampoo. So you can use Johnson or Himalaya baby shampoo. You can even clean the cornea with it. So it's very, very, very safe. So we use that before our surgeries, if it's a very gunky eye. So you can use the tear-free baby shampoo to clean the area. And even if you feel that it's still okay to push the eyeball in, do not push the eyeball in. So this is what is happening when the eyeball has been proptosed. So the eyelids have gone in. Okay, so when the eyeball comes out, the eyelid margins have turned in. Okay, so the eyelid margins turn in, the eyeball comes out, Okay. And these eyelid margins are actually acting like a wedge. They are not allowing they will not allow the eyeball to go in. Okay. Unless you apply a, tremendous amount of pressure, but it's not something that should be done ever, because in case if the eyeball is still intact, in case the nerve is still intact, and if you apply too much force, it can actually rupture the eye while you're doing that. Okay. So what you need to do is you need to just remove this lock here. Okay. There is a lock here which is formed by these eyelid margins. So what you need to do is you just need to release this lock. Okay. um, if you can see this picture here. Okay. So you just need to release this lock. Okay. The way you release this lock is just take take your 40 suture material. I usually use 40 silk because it's soft. I don't like using hard suture materials for the eyelids. I mean, in this case, I would use Prolene. So you just need to use your needle and dig that, the eyelid margin out from both the sides. Take 3 of these sutures. So you basically go in from here. Okay. uh, Pull this eyelid margin out, come out, keep this portion, this loop. Okay. Keep this loop intact and come out from the other side of the eyelid margin. Okay. And make 3 of these loops. Apply a lot of lubrication on the surface of the cornea. Okay. You need to apply a lot of lubrication constantly on the surface of the cornea so that it doesn't dry up. Okay. So these 3 loops, and keep something like your thumb forceps, the back side of your thumb forceps as a protection to the cornea, so that this suture material or these loops of the suture material don't rub against up against the cornea. And then you just pull these these ends. When you pull these ends, the eyelids, basically you just need the concept is not to push the eyeball in. You just basically lift the eyelids out, and then the eyeball slips back in. Okay. It's very easy, very simple, and very quick. Okay. You can actually finish this surgery within 10 minutes. So and when you do this, okay, you basically suture these sutures. There are like 3 4 whatever number of sutures that you feel you need to take. And you completely close the eyelids. Don't leave, I mean, you don't need to leave any holes. You don't only suture halfway. Okay. The entire eyelid needs to be, closed. And then you leave those sutures in for 10 days. Okay. So this, you just need to keep the eyelids closed for 10 days. That's how you fix it. And if the owners are well prepared that anything can happen once you open these sutures, then it's less of a trauma to the owners and to you. Okay. If you tell the owners, I mean, if you don't discuss anything and you just go and fix the eyeball in, and if the animal has no vision, or if the animal has a very prominent eyeball where the eyeball is actually falling out, after you suture, after you remove these sutures because of lack of enough extraocular muscle support, then it's not a very good, the owners don't relate to that very well. Now, eyelid tears. If you, I mean, this may not seem like an emergency, but actually it is, because every passing day, if you get a case like this, okay, this is a horse. They tend to get a lot of eyelid lacerations, but even dogs get a lot of eyelid lacerations, especially stray dogs or dog fights. You see a lot of eyelid lacerations. Okay, so the longer you leave this, just because you're dealing with something else, a stronger scar tissue is forming within here. Okay. Now this eyelid, as this eyelid margin, having an eyelid margin is absolutely necessary. If there is no eyelid margin, and if there is no functional eyelid where there is an actual blinking action, then the eye is as good as lost. Okay, if there are no good eyelids which are blinking over the cornea, which are not, because the function of the eyelid is not just to protect the eyeball. Okay, it is, every time you blink, a new layer of tear film forms over the eye. Okay, the eyelids help in forming, in spreading the tear film properly over the cornea. um, so, and it also has glands which produces a part of the tear film. So if the eyelids are not normal, or if they're abnormally shaped, then eventually this eye, the eyeball, or sorry, the cornea scars, and it develops constant ulceration. So it's not a good idea not to have good functional eyelids. So if you don't suture this quick enough, it's going to form a significant amount of scar, and that significant amount of scar uh, will not allow you to suture this eyelid in a proper way, when if you try and go and suture this after 2 weeks. Okay, you need to get in as soon as possible. You need to explain this to the owners, that I need to suture this eyelid, even if your dog has some other wounds on his body. I also need to suture this. Okay, you need to suture this as soon as possible. So I use 50 soft suture material. The reason I use soft suture material for these cases is because we don't want, in case any of the suture breaks, or any of the suture comes loose and starts rubbing onto the cornea, it should not that should not cause an ulcer. Okay, when you use a softer suture material, so I use Vicryl, 50 Vicryl, and five Vicryl tends to cause a little bit of reaction in the skin, but it's still more preferable than Proline. Okay, that again, as I said, it's mainly so that it doesn't cause a corneal laceration, a corneal ulceration. So the way I suture this, okay, you have to suture it in 2 layers. Okay, so the inner layer needs to be sutured. So the conjunctival and muscular layer, I first take that as my suture line. So I would start from here, and I would suture the conjunctiva and the muscular layer. Okay, and then the external skin layer and the eyelid margin. So this, in this case, the eyelid margin will need to be sutured um, at the lateral canthus. But in a case where there is a laceration right in the middle of the eyelid, right in the middle of the eyelid. So in that case, this is a 8 knot. Okay, this is a little tricky. I mean, there are some videos on the internet where you can follow this, but this 8 knot has the concept of this 8 knot is that the knot doesn't sit on the eyelid margin, and the knot should not, any of the knots cannot be near the cornea. They cannot be facing the cornea. All the knots need to be outside, again, so that the knots don't rub against the cornea and cause more damage. Okay, so the knot needs to be on the skin, and for that, this is called as 8 knot of the eyelid margin. Okay, and always keep the knots on the outside towards the skin. So this is what happens if you let go of the eyelid, of the eyelid injuries. Now in this case, this cornea is so scarred that we actually had to remove this eyeball. Okay, this dog, this puppy rather, has this functional eyelid here, um, and still a cornea is good. But even if we suture it, I mean, we can try, but even if we suture this this eyelid and remove as much scar as possible, it's still not going to be a good functional eyelid. And this dog will eventually develop some scarring, some corneal corneal damage. Now, entropion with corneal ulcer. Okay, I see this. It's a very, very common condition that I see in Persian cats and in chow chows. Okay, chow chow is somehow the, it's a breed that everyone wants to buy these days. I don't know why, but maybe they look like lions, or it's not a. I would never go for a chow chow. But chow chows, they have so much of folds on their skin. They look, I mean, as a puppy, they look divine. They look the cutest puppies in the world. But as they start growing, the number of folds start increasing, the eyelids start turning in, and then the corneas develop corneal ulcers. Okay, they just, these I get these puppies in my clinic, who are bumping into things because they just don't want to open their eyes. Okay, it's again a very very common condition in Persian cats. It starts with cat flu. Sometimes the ulcer comes first, and then because of the ulcer, because they're constantly squinting in that eye, the entropion develops, and then the entropion doesn't allow the ulcer to heal. So in these cases, in Persian cats, sometimes it's the ulcer that comes first, followed by entropion, and then the entropion makes it worse. Okay, now imagine there is a corneal ulcer, and there are multiple needles which are constantly rubbing against that ulcer. Now these corneal ulcers, as I mean, the cornea is a fairly thin structure. It's only 0.5 millimeters thick. So as the ulcer keeps getting deeper, I also see a lot of chow chows with ruptured corneal ulcers, because of the entropion. So this is an emergency. If you don't correct this entropion, if that ulcer, this ulcer is going to go deeper, and this ulcer is going to rupture. So the first thing that you see whenever you see this, you, the first thing that you need to do is correct that entropion. If you have diagnosed entropion is a problem, entropion is the root cause of this problem. Okay, now in these cases, even though the entropion is not the root cause, but it is a, it's threatening that this ulcer goes deeper. Okay, in these cases you need to, it's a simple, in these cases it's a very simple surgery. It's just a Halsey's technique, where you remove 1 centimeter skin, the strip of skin, and suture it, and miraculously these animals get better. Okay, if you keep treating these with eye drops, it's not going to help, because as long as there is a constant physical trauma, it's going to get worse. Okay, so you need to treat it with surgically, and this is 100% surgical condition. um, in chow chows, unfortunately it's not that simple, because in chow chows you need to actually remove an entire skin fold. Unless you remove the entire skin fold, the entropion keeps recurring. And we actually do that surgery when they are a little mature, unless the entropion is quite severe. Facial nerve paralysis. Now this, so when you look at this, when we first got this dog, a very cute dog, 3-year-old, his name is Habibi, and he first came in for neurogenic dry eye. This eye was a little dry, and there was a corneal ulcer. He had palpebral reflex, and within 3 days the owner sent us a video of this dog not able to blink. And that is an absolute emergency, where if the animal cannot blink, okay, if the eye is constantly remaining open, this ulcer will never heal, and this ulcer, the cornea becomes dry, and the ulcer goes deeper. So unfortunately, this dog was diagnosed with a brain tumor, and he had developed a facial nerve paralysis. This eye was visual. So what we did is we called the owners in, and immediately, as soon as he sent us the video, we called him in, and we did a temporary tarsorrhaphy. We also placed, we also did a third eyelid flap. Um, I mean, this is one of the very few cases where I would do a third eyelid flap. Um, so we did a third eyelid flap and a temporary tarsorrhaphy, just so that, hoping that the we didn't know that he had a tumor at that stage, but we were basically hoping that once this facial nerve paralysis episode gets better, once he starts blinking on this side, we will open the tarsorrhaphy, and he will be fine. Unfortunately, after we did this, we found that there was a tumor, and we knew that there was no way that he was getting any um, you know facial, his function, eyelid function back. So after discussing with the owners, we did I did a lateral canthoplasty, where half of his eyelids were sutured, and only a little bit of portion was kept open, because he was visual in this eye. He was absolutely visual. And when we opened the temporary tarsorrhaphy, the ulcer had healed and it was looking brilliant, beautiful eye. And he was the owner was absolutely, he was a very nice owner, and he would constantly treat this eye with a gel, lubricating gel. But within about 2 weeks, the owners came back, saying that there is a new ulcer. Even though there was a very little space left, and even though this eye was constantly lubricated, the dog again developed a corneal ulcer, because there was a lack of eyelid function, and we had to remove this eyeball. It was a visual eye, but we had to remove it. And so this is a this is an emergency where you have to close these eyelids. Okay, the longer these eyelids are open and not blinking, the eye is drying out, and it's basically it develops a corneal ulcer, and goes deeper. Cat flu, it's a very very common condition in kittens. Now, cat flu is it's a layman's term. I would usually when I see kittens like this, it's usually the feline herpes virus or chlamydia. Um, so I usually treat both of them at the same time. So it's very very common in kittens, and it needs to be treated as soon as possible. Lot of kittens are brought to us when the eyeballs are already ruptured. Okay, and in those cases there's very little that we can do, unless, besides, in terms of saving the vision, but we can save the life of that animal. So as soon as I see these cases, you need to measure their weight exactly. Okay, because most of them, they come in litters. Most of the, these are all Persian kittens, and the owners bring like 6 kittens, and you have to measure them separately, because there's always a runt of the litter who is 100 grams less than the others, so that you're not over dosing them. So in these cases, I start them on doxycycline, 5 milligrams per kg body weight BID, twice a day for 10 days. This is mainly to treat the chlamydia. Okay, so I'm assuming in these cases, sending it for PCR or doing a culture and sensitivity in these cases is, in my opinion, it's not required. um, so doxycycline for chlamydia, to cover the chlamydia, and famciclovir at the rate of 90 milligram per kg body weight twice a day for 14 days. Now there are various dose rates out there. There are 45 milligram per kg body weight TID. 3 times a day. That dose rate is also available. But giving cats oral medication is not a easy thing. So twice a day for 14 days is a better, is in my opinion, it's much better dose rate, and it doesn't have it. I've never seen a toxicity because of famciclovir. And you can give famciclovir, you can give doxycycline in these young little kittens, as long as you give it with food. Okay. um, Topical antibiotic in these cases, any antibiotic should do. You can go even gentamicin, because all this is not, it's not a topical problem, it's not just an external problem, it is the virus which is causing this. If you do only these two, this kitten will do better. Okay, but topical antibiotic is just to give it a little bit of boost. Okay. um, Artificial tears, because all these herpetic kittens have dry eyes. Okay, they have so in these cases, when I choose the artificial tears, I try to choose the hyaluronic acid drops. Okay, so hyaluronic acid, any artificial tears containing hyaluronic acids, they help these kittens much better. Okay. um, and the owners need to be explained that you have to always clean the eyes, and before you put the eye drops in. I also, there's one more thing that I forgot to add here, but I also start them on immunoboosters containing L-lysine. Okay. If you are presented with a kitten like this, I always, if their eyelids are closed, then I personally keep them in the clinic. I put them local anesthetic drops in the eye, and then thoroughly clean the eye, clean the gunk out, and see if there are any adhesions. Okay. Now these adhesions happen because the conjunctiva is so inflamed that inflamed conjunctiva wants to stick to something. Okay. And that conjunctiva, this inflamed conjunctiva sticks to each other. Okay, so the top eyelid and the lower eyelid can join, can attach to each other. Even the conjunctiva can attach to the cornea. The conjunctiva can actually destroy the sems the sorry, the herpes virus can destroy the stem cells in the limbus, and the conjunctiva can attach over the cornea. Okay, so all these things, if you don't break these adhesions now, then they basically become permanent adhesions. And these permanent adhesions, once they are formed, once these adhesions are more than 2 weeks old, there's very little that you can do anything about it. Even if you cut them, you can probably make the eyelid margin a little bit open up. But usually these eyes are, I mean, these adhesions, no matter what you do, even if you remove these adhesions later, they reform. Okay, so once you if you get a kitten like this, if you start them on the treatment like this, then they start looking like this within a week's time, and the owners love you. Okay, so this is this is a kitten that was presented to us. This is actually one of the vets in Pune, Dr. Aditi, her sister's cat, her sister's kitten. And basically it was presented to us like this. When, I mean, you can actually see that the adhesions have already formed, and you can see that it's probably 1 week old adhesion. And when I removed these adhesions, okay, there was actually a functional eyeball inside. And this functional eyeball was, fortunately, the stem cells and then the cornea was all normal. So I've got a little video for you just how to treat these adhesions. So basically, right now I've just removed this. Okay, these were adhesions. So you have to break the adhesions, put paracaine eye drops, okay, and then go in with the you don't need to sedate them. With the twisting moments, you just have to separate these adhesions. Okay. So this is highly inflamed right now. Okay. But then I have separated the adhesions right now, and if we don't keep on doing this, this will be adhered to each other permanently. So keep on doing that every 2 to 3 days, or every day maybe if you live close by, because this is this can actually get adhered very permanently. So what I meant in this is, I had opened or I had broken the adhesions that time, but the adhesions can happen again. Okay, as the animal goes home, and if it's not checked every day, these adhesions can form again, as long as if the inflammation is still there, the adhesions can form again. So you just have to keep on checking these kittens until all the inflammation has gone down and they are opening their eyes properly. Because if you break the adhesions and then if you let go, the adhesions can reform, and it's not a good scenario then. So while you do this, you also need to start them on all the other systemic treatment as well. So basically, okay. So severe corneal edema. Uh, I see this very commonly in anaplasma infections, especially in young dogs, young puppies. This is a 6-month-old German Shepherd puppy, and he was brought to us with bilateral corneal edema with this eye. He was unable to close because if you can, I don't know whether you guys can appreciate it, but this cornea is so edematous that he can't even close the eyelids. He cannot even close his eyelids, and this is an ocular emergency. And the owners need to understand that this is an emergency, because no matter how many hypersol eye drops you put in this eye, it's not going to, this cornea is not going to be protected. This cornea is not going to, the edema is not going to be, it's not going to go away as quickly as we want. The hypersol will not be able to solve this issue. So what you need to do is you need to basically apply pressure, apply bandage, apply pressure on the surface of the cornea, um, in order to get and in order to push this edema out. Okay. The one of the very very few times when I would do a third eyelid flap, and this is the only way that you can treat this kind of edema is is put to put the third eyelid flap. Now I would not put the third eyelid flap blindly in this case, in any of the cases which look like this. I have another case that I'll discuss with you guys later in the next few slides, which looks similar to this, but that case has a deep corneal ulcer, and I would never put a third eyelid flap on that case. So in this case, I had already checked that he had Menace reflex. He had a pupil that I could see through this edema. So the way you can do that is you need to use a very strong light, and in different angles I can actually see their internal structures. um, so this is the same dog, after we opened the third eyelid flap after about 2 weeks time. Okay, so as you can see, there is still a little bit of edema, but the edema has subsided significantly. There was corneal edema in this eye also, but this eye we didn't treat with the third eyelid flap. We just treated medically, and we treated the anaplasmosis. Okay, so anaplasma infection can cause severe edema similar to that. So the way we do a third eyelid flap is, take a non-absorbable suture material. Okay, so in this case, I would use Prolane. Okay, and start from the outside. Again, there are videos online how to perform third eyelid flap, but the important parts of the third eyelid flap is, at any stage, okay, the suture should not be able to rub against the cornea. The suture comes from outside. Okay, you basically loop I mean go around the third eye, the vertical portion of the third eyelid, the cartilage, and make sure that this needle, when you're passing through this needle, you have to make sure that the bulbar side of the third eyelid conjunctiva, there is the needle cannot be, the suture is not poking out from the other side. Okay, the suture at any stage should not rub against the cornea, because it will most certainly cause a corneal ulcer. Okay, so basically you come from the skin side, from the top, this portion. Okay, you go in, you loop your suture around the T portion of the third eyelid cartilage, and you come out again from the skin, and then tie the knot. Okay, and it needs to be tight enough so that you should not be able to see any part of the cornea. Okay, if it's loose, then this portion of the suture may rub against the cornea. So it needs to be nice and tight. Okay, but the knot outside can be long, because so that you can find it and cut it later. And when you do a temporary tarsorrhaphy, make sure that at any stage the suture cannot cannot come in contact with the cornea. When you're taking a bite, it needs to, the easiest way to remember this is that it needs to go through the opening of the meibomian gland. It needs to go directly from the eyelid margin. Okay, it can go directly on the eyelid margin, and when you tighten the suture, it needs to be nice and tight. Okay, if you intend to keep the temporary tarsorrhaphy in for more than a week, then I would use a non-absorbable monofilament suture material like Prolene. But if it is going to be, if it's only after a surgery and if it's only one stitch, then I would use a softer suture material like Mersilk. Okay, Mersilk causes reaction, whereas Prolene doesn't. But I would rather have a eyelid reaction than have a corneal ulcer because of the hard Prolene. Now, corneal ulcers. This is a structure of the cornea. Cornea is only 0.5 millimeters thick. Okay, it's so it's made up of 5 different layers. Okay, there's the precorneal tear film is one of the layers also, but not really the anatomical layer. So corneal epithelium, there's basement membrane. Okay, then there is stroma. This stroma is, the cornea is actually transparent because of 2-3 different reasons. The Actually, the cornea and sclera are made up of the same collagen fibers. Okay, but cornea is transparent because the collagen fibers in the stroma are in absolute perfect parallel. They are arranged in absolute parallel fashion. Okay, if this structure is disturbed, if the parallel, I mean, if they are no longer parallel because of a scar tissue, or because of the edema, the transparency is lost. Okay, so this about 70% of the cornea is made up of corneal stroma. Then there is Descemet's membrane, and underneath the Descemet's membrane there is a single cell layer called as endothelium. So the second reason that the cornea is transparent is because there is absolutely no fluid within the cornea. Cornea is a very dry structure. So even if the cornea is bathed in fluid from outside with the tear film, and then inside, because of the aqueous, the epithelium and endothelium, they flush the water out. They're constantly there. It's a constant process. Even if there is a constant um, presence of fluid, the epithelium, outside epithelium and inside endothelium, does not allow the water in. It's a watertight seal. Now, if this seal is broken and if the water gets in, okay, this seal would get broken if there is a corneal ulcer on the top. Then the fluid gets in, and then the cornea starts becoming blue. The reason the cornea becomes blue is because the fluid gets in after a corneal edema, after a corneal ulcer. If there is a penetrating corneal injury, okay, if the endothelium is damaged, if the endothelium is um, not is degenerated, then the fluid starts getting in, and then the cornea can become cloudy. Okay, so there are various reasons why the cornea can become cloudy, but the cornea becomes cloudy because the fluid gets in. Okay, so in this case here, you can see that there's a moderate corneal edema around this corneal ulcer because the fluid is within the layers of the cornea. Now, corneal edema in general is in this case, even though that is the one which gets the owners scared, but that's not the scary part, because having fluid within the cornea is not a major problem. It's this which is a major problem, and this needs to be treated. Once you treat the corneal ulcer, once the seal is back again, the fluid gets out, and then the cornea becomes transparent again. Okay. So this is a pretty amazing meme that Dr. Kamal Kumar, that who works for me here in Pune clinic, he's very good at it. So yeah, it's something that we make joke of. It's pretty cool. So, but it's very serious. So do not use steroids. Okay, otherwise we'll make fun of you. Please don't make steroids on the cornea. If there is a corneal ulcer, if you even feel that there is a pain or discomfort within the eye, do not use steroids. Do not use Ciplox D eye drops. Ciplox D are worst. Okay, Ciplox D, Moxie PD, okay, ketorolac eye drops, so Ophthocare KT, all these eye drops, or Fleur for that matter. I know some people like to use Fleur because they feel that how are they going to manage pain if there is a corneal ulcer. If there is a pain, if there is a corneal ulcer and there is pain, the thing that you have to remember is that can treat this by giving this animal systemic pain relief. Okay, systemic pain relief is the most effective way of treating corneal ulcers. Okay, you don't need to put painkillers on the surface of the eye to make them feel better. You can actually give them oral or injectable painkillers to make them feel better. Okay, so there are different types of corneal ulcers. Any kind of corneal ulcer is an emergency because the owners freak out, because the animal becomes extremely painful. Okay, any scratch on the surface of the eye, any because the cornea has open nerve endings, and open nerve endings when they're exposed, it's extremely painful. Okay, so there's superficial corneal ulcer, there can be stromal. So basically superficial corneal ulcer is only scraping the epithelium. Okay, stromal corneal ulcers, they go deeper. Okay, they are within the stroma. And desmatoseals are, they have the ulcers which have reached the descemet's membrane, and these are surgical emergencies where you have to perform corneal grafting procedures, because these eyes can rupture any moment. There are ruptured corneal ulcers and then the melting corneal ulcers. So any uncomplicated superficial corneal ulcer usually heals within 3 days. If there is a wound on the surface of the cornea, most of the times without any treatment, these ulcers can heal. Okay, 3 to 5 days is maximum that the ulcer needs to heal. If these ulcers don't heal within 3 to 5 days, then in my opinion, they start becoming uncomplicated non-healing corneal ulcers. Okay, so in these cases, what I do is I just do a cotton tip debridement under local anesthetic. Um, a broad spectrum antibiotic, because I mean it's not because these ulcers are infected, it's just because the natural flora of the within in the eye can they can overgrow. There could be overgrowth of natural flora and can cause damage to the ulcer. So that's why we start them on broad spectrum antibiotic. Okay, uh, whenever there is a corneal ulcer, any corneal ulcer can lead to uveitis. Okay, and because the cornea is so sensitive and can be so painful, that the eye can actually get internal inflammation. Okay, it can actually start getting uveitis within the eye. So I see a lot of these corneal ulcers with hypopyon. Okay, they have significant uveitis, and you cannot just treat. In these cases, you cannot just treat the ulcer. Okay, whenever you see the ulcer, you need to start managing the uveitis as well, whether there is a uveitis or not. Just expect that there's going to be a uveitis. And in these cases, I would start them on atropine eye drops or ointment. In case of cats, I like using an ointment. So twice a day. Systemic pain relief, not topical. Do not treat them with topical pain relief. Start them on I start them on oral doxycycline. And yeah, do not use Fleur, ketorolac, or steroids. Okay, doxycycline, prednisolone. If you're not sure, just treat it with antibiotic and lubricating eye drops. Okay, if you, I mean, because of antibiotic and lubricating eye drops, you cannot do more damage. Okay, but by using the steroids or NSAIDs, you have a potential to make it worse. Okay, Stromal corneal ulcers are the ulcers which have potential to become descemetocele. So any stromal corneal ulcers, you need to, take them a little bit more seriously than the superficial corneal ulcers. I usually check them on next day, or if the owners can't actually make it to the clinic, I show them how to take a picture, a good picture, and I ask them to send me the picture every day. Okay. Uh, in very few cases, I actually like using corneal glue. The reason I say few is because if the ulcer is very big, I don't use corneal glue. If the ulcer is small enough, I would say 3 millimeter ulcer, a deep stromal corneal ulcer, the ulcer which is not ruptured. If there is a ruptured corneal ulcer, or if it's a descemetocele, the glue doesn't work. It has to be a stromal corneal ulcer. The reason I say it doesn't really work with descematoceles is because the ampullate does not stick to the descemet's membrane. So in these cases, as I've seen, I mean, in previously, I've seen that the glue can fall off. Okay. Now the ampullate is like, I mean, it's similar to the super glue. Okay. So it's like, it's fluid that you can aspirate in a syringe, and you just need one tiny little drop. Okay, it's not even a drop, just the top, a very very little amount that you basically touch to the surface of the ulcer, and then it crystallizes. Okay, it crystallizes like this, and then in that case you need to take a temporary tarsorrhaphy. Okay, and you have to always warn the owners that the success rate of this surgery is, or corneal glue, is about 80%. The reason being that the glue can actually fall off, and then if the glue falls off, then it can actually open the wound even deeper, or even sometimes rupture the eye. uh, this surgery this procedure is much quicker. It requires fairly less surgical skills, but the success rate can be tricky, and you have to know what you're doing. If you use it in a much bigger area, then it, it's not it doesn't give good success. Melting corneal ulcers, these are an absolute emergency, because and I see this very commonly in horses and dogs. um, Most of the times they are infected. Okay, and pseudomonas is usually the culprit. So pseudomonas has the ability to melt. It actually has collagenases, and it starts melting. It starts breaking the collagen, and then it starts melting. Within few hours, the entire cornea can melt and fall off. Okay, so you need to treat this as if it's the eye is going to rupture. Okay, so as soon as whenever we get a case like this, as soon as I see a melting corneal ulcer, I start treating them. I don't really use serum for superficial corneal ulcers, or ulcers which are not melting. Serum has a very specific role in melting corneal ulcers. So serum has anticollagenases in it. Okay, and serum, when you put serum in these cases, you can actually start reversing or you can actually stop the process of collagenases. Um, I take the sample for culture and sensitivity, but because it takes 24 hours or sometimes a little bit more to get the results, I usually start them on topical tobramycin eye drops. Okay, so tobramycin goes in every hour, serum goes in every hour. In horses, sometimes, if the culture and sensitivity or the cytology comes back positive for fungal infection, then I start them on antifungal as well. So cytology results can come much quicker than the culture and sensitivity. So you also collect the sample for cytology. uh, Topical EDTA eye drops, they also help in stopping the collagenases action. And then you treat the uveitis as well. just like any other ulcer. So topical atropine, oral doxycycline, oral pain relief. And if it's not getting better, I usually wait for a day. Again ask them to come in the next day. If it's not getting better within a day and the cornea is still looking, melty, then I take them to surgery and put a graft on this melting ulcer. Deep corneal ulcers. So this is a descemetocele. Okay, so this has actually reached the descemet's membrane, which is actually which appears transparent. Okay, this is a ruptured corneal ulcer where the, if you can see, this is this is iris which is prolapsed. So this is a ruptured corneal ulcer. So all these are surgical emergencies where I take them to surgery and do a corneal grafting procedure. So I hardly ever do the conjunctival graft anymore. The reason I don't perform the conjunctival grafts is I only need to graft when the ulcer is very deep, and the conjunctival graft doesn't really give the tectonic support that is required for these deep or ruptured corneal ulcers. Okay, this cannot be placed in the ruptured corneal ulcers anyways. And when you actually cut this pedicle, this portion develops quite a significant scar. Whereas I like to do the sliding corneal grafts or corneo-conjunctival transpositional graft, is because this portion of the cornea, this is this is still a little bit of scar, right? I mean, there's still a significant scar here, and there's still blood vessels. But as we start treating this, to get rid of these blood vessels, this portion will become transparent. Okay, so central portion in the central axis, if this portion becomes transparent, it's much better than having a non-transparent area right in the center. So that's a sliding corneal graft in action. That's a descemetocele right in the center. This is a graft, and as you can see, this is 1 week after the graft, and as you can see, this portion has already become transparent. And this has, I mean, usually the results are pretty good. So there's a little video of it's in fast forward, because usually it takes about this is a ruptured corneal ulcer. Usually it takes me to it takes about 45 minutes to do this. So what I'm doing here is I'm separating the good cornea, the transparent and healthy cornea adjacent to the ulcer. As you can see that there is a ruptured portion right in the center, and then the iris has prolapsed. So I've separated the graft portion, uh, preparing the graft bed. This is done under operating microscope, and it's done very, very gently, even though it appears a little harsh with the fast forward, but it's done extremely gently, because there is a rupture, and if you can notice that this eye is very soft, so there's very little support from within. Okay, now I'm basically separating the conjunctival part of the graft, because conjunctiva comes forward as well. So that's the part which is not healthy. I'm just making sure that the iris, just injecting some viscoelastic material and making sure that the iris is away from the cornea, because if I put the graft on and if the iris is comes forward and gets stuck to the grafted portion, then it can actually lead to glaucoma after we seal this hole. So the suture material that I'm using is 10-0 suture material. These are two anchor sutures. After taking the anchor sutures, the entire length of the graft is sutured with continuous layer. Okay, so this is the case that I was talking about with the corneal edema. There was a ruptured corneal ulcer, and this puppy, it was a 3-month-old puppy, and he couldn't really close his eyelids because of the corneal edema. If you can see that this lower eyelid is just getting here and not passing any further than that, and that's why this line has come over here. So this picture is taken from the side angle, just so that we can appreciate how edematous this cornea is. And the reason for this edema is because of a rupture, because of a through and through rupture. uh, the endothelium is breached, okay, and the fluid, the aqueous, is actually leaking into the layers of the cornea, and that's why this cornea is so edematous. Okay, we did a sliding corneal graft on this, and this is about 3 months after the surgery, so it's looking brilliant. um, One of the most brilliant recoveries that I've seen after the surgery. But this is where the graft is, and as you can see, it's fairly transparent. It's very, very transparent, and actually this animal can see um, through this graft. Now, Vetrix biosis graft, it's a graft that we buy from. It's a ready-made graft. It's a swine small intestine mucosa, and I mean, you can actually, it comes in sheets, and you can suture that. You can use that as a graft, and you can suture it on the ruptured ulcers, or you can even use it for descemeter seals. The only downside is if it melts away before the cornea heals, then you're back to square one again. And it has happened to me before. So I still, and for bigger ulcers, I still prefer doing the sliding corneal grafts. Now, corneal sequestrum is necrosis of the cornea at a particular spot. This happens, in my opinion, it happens to after feline herpes virus infection. Usually, I mean, in some cats, they develop non-healing superficial corneal ulcers. And in cats, these non-healing superficial corneal ulcers, eventually, if they're not treated, if the ulcers don't heal, then eventually they have a potential to become corneal sequestrums. And it appears like a little brownish spot, okay, a little bit of brownish pigment on the surface of the cornea. And it may appear a little harmless, okay, but in some cats it can grow very slowly, whereas in some cats it can grow very, very rapidly, and it can go deeper within the layers of the cornea. Okay, if it reaches the descemet's membrane, then when you perform this surgery, you have to remove each and every cell, each and every black bit, each and every pigment that you see. So it has to be done under the microscope, because If you do it, if you don't do it under microscope, and if you leave a little bit of tissue inside of the sequestrum, then it can rapidly grow back again, and then again you are back to square one. Okay. um, so in initial stages you can actually remove the top layer, and no need for grafting. But as it goes deeper, and if after removing the sequestrum, if the defect is deep enough, you will have to graft this portion. So it's better that you get on it early, and that's why it's an emergency. If you see this, you need to act on fast and remove the sequestrum as soon as possible. So this is a nice case. We saw the cat with sequestrum. If you can see here, there's a pigment here. Um, and then the owner, very vigilant owner, actually she noticed this pigment and watery discharge from this eye only 3 or 4 days ago. Okay, only 3 or 4 days had passed, and then the owner had seen the pigment. We couldn't do the surgery for 1 week because it's not, I mean, sometimes you can actually push them for a week. uh, the next week when we saw the patient, and he was actually in for a surgery, so this was a surgery day, which is 1 week later. Okay, can you tell the difference? I mean, you can actually see the structures inside structures here, whereas here it's looking horrendous. Okay, this corneal sequestrum had, attracted a lot of inflammation, a lot of vascular response, and the sequestrum had gone deeper. So then we had to do a graft. We had to do, I did a sliding corneal graft. And if you can see, this portion here is also part of the graft. Okay, so it's become beautifully transparent. This is the conjunctival part. In cats, they heal amazingly, amazingly. So this is a one of the very, very good examples of sliding corneal grafts. Now, uveitis, I have already gone through what UVI is, but I'll go through it again. Iris, ciliary body, and choroid at the back. Okay, these are highly vascular structures, and these three together, okay, they make the uvea. Okay, now uveitis is inflammation of the uvea. Sometimes, we say anterior uveitis. Sometimes we mention posterior uveitis. Posterior uveitis means inflammation of the choroid. Anterior uveitis means ciliary body, involving ciliary body and the iris. But it's never really anterior and posterior. It's always, whenever there is uveitis, it always has some degree of uveitis in the choroid as well. Okay, because all of these structures are connected to each other. Okay, so you need to, and whenever there is uveitis, you cannot just treat it by putting drops on topical eye drops. Okay, you have to treat it systemically as well. So if you don't treat uveitis systemically, you will not be able to effectively manage the uveitis. So whenever there is uveitis, these are the very common signs that the animal presents with. There's squinting, there is redness, aqueous flare. Okay, so I'll just explain what aqueous flare is. This is a normal eye. Okay, this is a slit lamp. You can only check aqueous flare with the help of a slit lamp. Okay, or there should be a slit beam. Some of the direct ophthalmoscopes have slit beam on them. But yeah, so this is a slit beam, and this the first beam, or the first line, is on the cornea. It's passing through the layers of the cornea. This is the thickness of the cornea. There's nothing, absolutely nothing in between. Okay, so basically this is the aqueous chamber. So because there are no cells within the aqueous, the light is passing right through it. Okay, and then it's falling onto the iris and then the lens. Whereas in this dog, okay, this is a cat. In this dog, there is a this is the cornea. That's the lens. Okay, and between the cornea and the lens, this is the aqueous. If you see this column here, this is actually lighting up. Okay, this is called as aqueous flare. Okay, aqueous flare means that the light is actually reflecting, or it's falling and reflecting on the cells within the aqueous. Okay, the aqueous, which is supposed to be absolutely cell free, it cannot have any cells, now has cells within the aqueous, because the blood ocular barrier has been breached, and then the cells have entered. Usually these are either red blood cells or white blood cells which have entered the aqueous, and it's a pathognomonic sign of uveitis. Okay, in some of the cases you actually see hypopion, which means that the like basically pus in the anterior chamber. Sometimes you can see blood in the anterior chamber. So whenever you see an eye like this, okay, even though this is a cat's eye and this is a dog, but the if you do a fundoscopy exam, you can actually see blood. I mean, you can actually see hemorrhage in the on the retina. So if you see an eye like this, always perform a fundoscopy exam. Always expect that there is a chance that this is not only in the front. Okay, just putting Ophthocare KT eye drops is not going to solve this. You need to look for the reason for this. Okay, usually right now in this season for our country, we this I see uveitis. If I see a uveitis in dog, it's usually tick fever. Okay, so if you see a red eye like this, always do a blood test. There's no harm in doing a blood test. Just do a blood test, look for tick fever. This can happen also in dogs with severe systemic neoplasia. I've had cases where the dog presented with bilateral uveitis and later on detected with splenic hemangiosarcoma. Okay, the usually we get presented with lymphoma cases, and severe uveitis, severe retinal, I mean complete retinal detachments, sometimes optic neuritis. So any of these cases can have any of the severe systemic inflammations, severe systemic diseases can cause uveitis. So look for the root cause. Okay, so always perform a blood test, and make sure that you don't just treat the front portion of the eye. You should always go for the, I mean, make sure that you are not neglecting the back. So hyphema, again, the similar reasons. Right now I mean in India, tick fever is something that we see all the time, and this is the main reason that the animals usually are presented with hyphema. So do the blood test, check for blood parasites. If the blood test comes back absolutely normal, then do a clotting test. Do any of the, I mean, unless there is a significant, unless there is an absolute confirmatory history of trauma and there is hyphema only in one side, then it could be trauma related. But if it has happened in both the eyes, it's too much of a coincidence, and you need to look for any systemic diseases. Okay, treatment of uveitis, the way we treat it is you find and treat the root cause. Because if you are treating the uveitis without treating the babesiosis, then ultimately the dog is going to die, or the uveitis is not going to come under control. We find uveitis in cats very commonly with the one of the deadly viruses. Sometimes other things like toxoplasma, trypanosoma, coccidiosis. So all these sorry, cryptococcosis, all these conditions can also cause uveitis in cats. So systemic antibiotics, I like doxycycline, and systemic anti-inflammatory drugs. If there is if you are absolutely sure that there is no corneal ulcer, then start treating them with topical prednisolone acetate eye drops. And the most commonly available are Predfort eye drops, um, 3 times a day. And then topical atropine, again, you have to be sure that there is no glaucoma. And then topical antibiotic eye drops. Any uveitis case can turn into glaucoma. Okay, if there are enough cells within the aqueous, okay, because of the uveitis, those cells can go and clog the iridocorneal angle. I've got the slide. Yeah. So this is how the filtration happens. The ciliary body form the aqueous, okay, aqueous humor. It comes out, circulates within the aqueous anterior chamber, and then is drained out from iridocorneal angle. Now iridocorneal angle looks like this. Okay, there are these tiny little holes, and these are pectinate ligaments and tiny little holes. This is like a sieve. Okay, the aqueous humor passes through this sieve and gets absorbed from here. Okay, the just imagine having enough blood, enough red blood cells or enough white blood cells to go and clog this. Okay, if this is clogged by the cells, the aqueous humor that is generated by the ciliary body constantly, um, if there is no way out, it's obviously going to stay in and is going to increase the pressure of the eye, and that's how the glaucoma can happen. Okay, this is a secondary glaucoma, not primary glaucoma that I'm talking about. Primary glaucoma can also happen if the iridocorneal angle is faulty. Okay, um, sometimes, so now I'm going to talk about glaucoma. So if this outflow is blocked, okay, this is the most common presentation in dogs and dogs that we see, okay, even in cats, is because the iridocorneal angle either is faulty or it is blocked. Okay, this can get clogged because of the cells, or sometimes the lens comes forward. Okay, if the lens has come forward, or if the lens has luxated and is sitting here in the anterior chamber, it can also clog the anterior chamber just by being there. Okay, just by as a space occupying lesion, it would go and block the iridocorneal angle. If there is a retinal detachment, the entire portion, the entire vitreous can push the lens forward. Okay, because the detached retina is pushing the anterior, pushing the vitreous forward, and then the vitreous pushes the lens forward, and then it also blocks the iridocorneal angle. Okay, so anything that blocks the iridocorneal angle, or if the animal is born with faulty iridocorneal angle where this portion is faulty, then also the animal can develop glaucoma. So primary glaucoma is goniodysgenesis, that basically the angle, the iridocorneal angle is not formed properly. Secondary glaucoma is, can happen because of uveitis, can happen because of trauma, lens luxation. Intraocular neoplasia can also cause glaucoma because again, it is a space occupying lesion, and if it blocks the iridocorneal angle, enough of the iridocorneal angle is blocked, then it can lead to glaucoma. Okay, now this is something that I see very commonly in huskies. I mean, husky puppies, or when they reach about 1 or 2 years old, they develop this primary glaucoma. This is something very, very commonly that I see, and it's probably the faulty gene pool that is there in India. Now, the symptoms of glaucoma, it's a red and painful eye. The, episcleral vessels, you can see they're supremely hot, red, inflamed, swollen. There's corneal edema. The corneal edema is because the eyeball stretches, the cornea stretches, and then the endothelium, there are gaps in the endothelial cells, and there can be fractures in the in the descemet's membrane, and then the fluid can seep into the layers of the cornea and cause corneal edema. As soon as the pressure comes down, the corneal edema gets better. Okay, increased intraocular pressure. If anyone, I mean, it's always better to have a tonometer in your, in your clinics. So if you have a tonometer, check the intraocular pressure. Fractures in the descemet's, optic disc cupping. This is something. And retinal degeneration is something that we see in a very end stage or older chronic glaucoma. And ophthalmos Not every glaucoma, not every acute glaucoma that presents to us has a big swollen eyeball. Okay. So sometimes it's very tricky to differentiate between glaucoma and uveitis, because sometimes they have similar presentation where the eyes painful, eyes red, there's corneal edema. The only way to differentiate at that stage is, usually in uveitis the animal still has vision, unless everything else is fine. um, and in glaucoma, most of the I mean in glaucoma the vision is, the animal is blind in that particular eye. So that's a very distinct differentiation that I see. And then if you have a intraocular, if you have a tonometer, then the intraocular pressure is going to be higher in glaucoma. And in uveitis, what we usually see is the intraocular pressure is low. So if you notice any of the above signs, you need to refer these patients as soon as possible. The way we treat it, you can, the way, you can treat it with Ophthocare XT, which is basically dorzolamide and timolol combination. But just by putting them on Ophthocare XT doesn't mean that the pressure is going to come down. Okay. If the pressure remains higher than 25 millimeters per mercury for 72 hours, the the optic nerve gets damaged permanently. Okay, you cannot reverse the blindness in these cases. They usually are permanently blind if the pressure has been above 25 for a significant amount of time. Okay, glaucoma is also very, very painful condition. Okay, it's like having a throbbing headache, constant throbbing headache. So you cannot take it lightly, because basically this animal has so much pain that either they're extremely quiet. Most of the times in acute glaucoma, they don't even want to eat. Okay, so what you can do is, you should refer these cases if you can, if you have someone around you to refer these cases to. But if you don't have any, if you don't have anywhere to refer, basically what you can do is you can start them on dorzolamide timolol combination twice a day. If you overdo this combination, especially in smaller dogs, timolol can affect their heart. So you cannot really overdo this. Okay, especially in cats. So, so dorzolamide timolol combination twice a day, brimonidine eye drops 3 times a day, and latanoprost eye drops twice a day. Okay, this is the maximum that you can go. If you want to go even more aggressive, you can give them oral anti-glaucoma medication. But I don't really like to treat them systemically, because they can actually develop hypotension. Systemic painkiller is absolutely essential. Okay, and check the intraocular pressure the next day. Okay, sometimes if you catch them early, okay, if we catch them early, then we can reverse the glaucoma by reversing the uveitis. Okay, if you reverse the uveitis, you can reverse the glaucoma and you can maintain the vision. Okay, and this has happened to me many times, where we have reversed this in just in time and we have managed to save the vision. Okay, but you just need to be very vigilant about it. And if you know about it, then you will be vigilant about it. Okay, in some of the cases, in some primary glaucoma cases, we can even place a aqueous shunt. This is a picture of an aqueous shunt. And not necessarily this is the answer to these glaucoma patients, because they tend to get clogged. Animals can get reaction to the shunt, the shunt material. So it's something like the end stage, one of the things that you can do before, as a last resort. Okay, and there has been success in treating glaucoma by using aqueous shunts as well. um, if the eye becomes gets to an end stage glaucoma, end stage glaucoma, with there is a when where there is a lot of pain and a lot of discomfort, there is no vision, then in those cases we treat them, by surgery. We give the owners an option of removal of the eyeball, or we can do a prosthesis, or we can give an injection within the eye which can shrink the eyeball. Okay, it's basically a gentamicin injection. I don't really like that option that much because it can leave a chronic pain in that eye. Okay. Anterior dislocation of the lens, as I discussed before, because of the presence of that lens, the animal can quickly go into secondary glaucoma. Okay, so you need to be very, very quick. If this eye is visual, we need to go in and we need to remove this lens as soon as possible. Okay, and most of the times, if this is done in time, then you can save the vision in these eyes. Okay, if this lens is left over there, because sometimes owners don't want to do anything about it, uh, if the lens is left in the anterior chamber, it's a very painful thing for the dog to have it in the anterior chamber, because it is constantly rubbing against the cornea, and it is very, very painful. Okay, so it's if this eye is blind and the owners don't want to go in and remove that lens, then remove the eyeball. Intumescent cataracts. This is mostly associated with diabetic dogs. In diabetic dogs, they sometimes, most of the times this happens is the dog was visual the day before, and then when they wake up with these bright white cataracts, and the dog is completely blind. uh, these are usually sudden cataracts, and this happens because uh, the sugar gets inside the lens, and then the lens sucks in water, and then the lenses swell up. Okay, and these swollen lenses start leaking. They can rupture, or they can start leaking the lens material out. And as you can see in this dog, there is an aqueous flare, and this means that this dog has already started, either the lens has ruptured or has already started developing lens induced uveitis. Okay, and these are surgical emergencies, and if we don't operate quick enough, the uveitis becomes so significant that the animal suddenly, and if the enough lens material ruptures and comes out, then the eye gets into anaphylactic reaction, and there is glaucoma and permanent loss. I mean, the eyes are permanently lost. You cannot operate them at that stage. And then the only thing good that you can do for that dog is to remove the eyeball. So these are some examples of intumescent cataracts. This is an ocular ultrasound, and if you can see that the lens is 0.92 centimeters. Okay, so this width of the lens should be 0.7 centimeter. Okay, the normal lens is 0.7 centimeter. 0.92 centimeter. This eye has already started. If you can see how red this eye is, this eye is in severe uveitis because of the lens induced uveitis. This is after the surgery, 1 week after the surgery. Same here. This is an intumescent cataract, 0.84 centimeters, and this is about 3 months after the surgery. So always do an ocular ultrasound. So if you don't have an ocular, I mean, the best frequency would be more than 12. But even if you have a normal ultrasound with 7 megahertz frequency, the way you do an ocular ultrasound is put some local anesthetic eye drops on the cornea, and then use your probe and put the probe directly on the cornea. Okay, that's the best way to get a good image. Okay, and measure the width of the lens. Okay, measure the width of the lens. If this is 0.89 centimeters. Okay, so all these are intumescent cataracts. These are some ruptured lenses. Okay, if you can see that the lens material at the equator, the lens usually ruptures. The lens material is leaking, I mean, ruptured, and is coming out from the posterior side. Sometimes it looks normal, but when you fan your ultrasound probe, you can see that the rupture is at some spot. This is my last slide. So retinal detachment. This is something that I very commonly see in tick fever cases. Okay, sometimes lymphoma can also look similar to this, but yeah. So with tick fever, or because I mean, always there is a systemic reason. Sometimes even high blood pressure can cause this. Dogs or cats, especially cats with chronic renal failure, can have high blood pressure and suddenly can detach their retinas. Okay, and so there is usually some sort of secondary reason for the retinal detachment. And as discussed before, this retina, as the retina detaches, the lens comes forward because the vitreous comes forward and blocks the iridocorneal angle. If you can see here, the iridocorneal angle is blocked, and then the animal develops glaucoma. So always expect that there is going to be a glaucoma. And yeah, do a blood test. If you see a dog who's gone suddenly blind, do a blood test. Thank you. I know it was a very long lecture. I'm done.
Thank
Hi,
you.
I have a few questions for you.
1 minute, ma'am. 1 minute. So thanks a lot, Dr. Kasturi, and she's free to take questions right now. Some questions are being already answered by Dr. Ritika, and some questions are going to be, answered by Dr. Kasturi because of time constraints. If you have more further questions or detailed questions, you can email to her. And yeah, over to you, Dr. Kasturi.
Thanks, Mira.
Hi.
Hi.
So, one of the first questions is that how do you differentiate between a third eyelid prolapse, a cherry eye, and a cat scratch?
So cat scratch, I mean, it is location, and differentiate as in you need to, if you are worried that there is if you see a lump which is red in color, and on the medial side of the, on the medial, in the medial canthus. And usually cherry eye is not really a painful condition, whereas cat scratch would be extremely painful, and there should be a history of a fight. And yeah, as I said, I mean, the cat scratch and the picture that I showed you was actually sitting on the cornea, and then there was an iris prolapse, whereas third eyelid gland prolapse is an extraocular problem. So you can actually see that the gland is, not on the cornea. So from the picture, I mean, I can tell the difference. But if you want to diagnose something from the picture, and if you're not very familiar with it, then you need to get the animal in and examine it.
Yeah. So the other question is what kind of antibiotics can you use in lavage, or what presentation can be used?
So there are sterile, preservative free, moxifloxacin antibiotics which are available, which you can put in the lavage. And usually I use RL to flush the, whenever I do a cataract surgery, I use RL. You can even use BSS, balanced salt solution, and you can actually put preservative free, sterile moxifloxacin into the lavage.
Okay. The other question is there any way to know if the muscles are intact before in proptosis of eyeball?
So I mean, if you can see, usually you can see that there is a rupture when you're putting the eyeball in. You can see it's, and the ruptures usually happen either on the medial or the rectal side, rectal muscles. And if you don't see anything which is ruptured, then most of the times the muscles are intact. So no way of, I mean, you can look for them, but most of the times you can actually see that they are ruptured, if they are ruptured.
One more question is, will the braiding of vicryl not cause trauma to the cornea?
Will the what?
Braiding of vicryl not cause trauma.
So 80, oh sorry, the 90 or 10 vicryl are monofilament. They don't have the this thing. But for the in terms of to the eyelids, when you're using 50 or 50 or 60 vicryl on the eyelid, then it doesn't cause as much trauma as a monofilament, because monofilament is like a, it's like a wire, so it can actually go in and puncture. It's very sharp. It can be very sharp and hard. Whereas soft, I mean, if there is a knot on the side of the cornea, and if the knot rubs onto the surface of the cornea of the vicryl, then yes, it will cause an ulcer, but it will not be a as severe ulcer as a monofill. And always make sure that your
Okay.
knots are away from.
Sorry.
So the next question.
Yeah. So, is there any process in veterinary ophthalmic surgeries, or do we get a prosthetic eyelid?
Your voice is breaking.
Can you hear me now?
Yeah.
So, do we have any prosthesis in veterinary ophthalmic surgery, and do we get any prosthetic eyelids?
No, not prosthetic eyelids. Prosthesis, as in we use intrascleral prosthesis. It's basically a silicone ball, silicone rubber. I mean, we import it from Germany. That they are also available in India, but they're very hard, and you can actually put them in the eye. I mean, in the shell of the eye. So when we do the intrascleral prosthesis, it's within the eye. So there are some scleral shells that you can get made from the human prosthetic people. And in when a person gets a prosthetic eye, is basically the entire eyeball is removed, and they get a silicone or a glass eyeball, and which they have to put in every day. They have to take it out every day, clean their orbit, and then put it back in again next day. So that's how it works with people. But it's not really a feasible option for animals, because the owners eventually get bored of it, and then they leave it in for too long, and then the socket gets infected. It's not really a good option. So what we do is we use intrascleral prosthesis. The eyelid wise, there's no I mean, you can do. So if there is lack of eyelid, or if there is a huge part of the eyelid which is missing, then we do a rotational grafts. So you can do grafts. You can use lip as your eyelid margin, and these are all complicated procedures which can be performed.
Yeah. One more question is, can we use acetylcysteine and alpha-2 macroglobulins for melting corneal ulcers?
Yes, you can.
Okay.
And acetylcysteine is you can use them.
Okay. Can we use silver nitrate cauterization in a corneal ulcer?
No.
Yeah. So one more question is gentamicin okay for corneal ulcers, or is it contraindicated because it stops the healing of an ulcer?
No, gentamicin eye drops can be used. It's a prophylactic eye drop anyway, so you can use them. No harm in treating corneal ulcers with gentamicin, as long as it doesn't have anything else like steroid or a NSAID in it.
Yeah. So it's not a question, it's a statement. I'll read it out. In intraocular pressure of two eyes in the same pets show difference of 5. It's reported to be glaucoma, even when the IOP is within the range of 10 to 25, as per a US ophthalmologist. Is that true?
So, I mean, when you check the intraocular pressure, it's always, you have to relate it to the clinical signs, because sometimes the brachycephalic breed dogs, they come in and they're struggling. You check the pressure and pressure is 40, but there are absolutely no clinical signs of glaucoma. So in these cases, what we do is we basically calm them down and check the pressure again. Okay. Sometimes the machine that you use can also show variations. So we have a tonovet they say that tone of it tends to show a little bit of higher pressure. There are multiple different methods that you can check the pressure. Not methods, there are multiple different tools that you can use. And there's always a difference. I mean, I wouldn't really get hung up on what is the difference between the two eyes. I mean, if one eye is showing 5 or 3 as pressure, and the other eye is showing 15, then that is significant, because then the eye that is showing low pressure is that it has uveitis. Okay. But if there is a difference of 5, if you check the pressure 5 minutes later, there's going to be no difference, or there's going to be a difference of 6. It's nothing major. I mean, as long as you have to relate it with clinical signs. So if I mean, that's my opinion.
Yeah. So another question is, how much gentamicin do you inject in the eye for shrinking it? And do you inject it in anterior or posterior chamber? And do you suck out some of the aqueous or vitreous humor before injecting genta?
Yeah, so good question. So that's it's not really for the ocular emergency lecture, and that's why I didn't really specify it. But yeah, you have. I mean, I never give it in the anterior chamber. I always give it in the posterior chamber, in the vitreous, and I do suck out about 1 ml of vitreous, and then I mean, I calculate the dose of gentamicin as per the weight of the animal. So I do not exceed 5 milligrams per kg body weight, for the animal. And usually I inject about 1 ml, so 40 milligrams in the
Okay.
chamber.
Another question is, how effective is grid keratectomy for corneal ulcers?
It is fairly effective, but you have to be very careful when you're doing the grid keratotomy, because it's not keratectomy. You're basically opening the cornea. So grid keratotomy is fairly effective, but basically what you have to be very careful that you don't go too deep, because if you go too deep, then you are creating these grooves for corneal, for the bacteria to go and lodge themselves. But yeah, it is effective in non-healing corneal ulcers, and I don't use it. I do algal brush debridement, which is much more safer.
Okay. Anything to delay cataract with a medicine?
No.
Okay. And is there any internship program available for the veterinary students at the clinic?
So we are, thinking of, employing more vets, and expanding into different cities. So if anyone is interested in ophthalmology, really interested in ophthalmology, do contact us on our. We have contact information on our website.
And lymphoma in relation to blindness. That's what the statement is. Like, what do you?
So yeah, I mean, lymphoma, which has gone out of hand, which is quite aggressive lymphomas, can cause retinal detachment. It can get into the iris, because it's a vascular structure. It can cause glaucoma. So yeah, we see a lot of blindness with lymphoma.
Okay. Yeah. And yeah, is tarsography better than conjunctival flap in a corneal ulcer?
No. So I would rather put a conjunctival flap than closing the eyelids. So whenever there is a deep corneal ulcer, it's always better to know what is happening with that ulcer. So doing just stitching the eyelids up will not be. You will not be able to see what is happening on the eye. Sometimes people do the temporary tarsography, or they do a third eyelid flap, and once they open it up, there is a ruptured corneal ulcer underneath it. So you need to know what is happening to that ulcer. Okay, if you are equipped to do a conjunctival flap, always do a conjunctival flap than a third eyelid, than a tarsography.
Okay. Yeah. Last question.
Whenever you do a tarsography, you can do it halfway, so that you should be able to see what is happening within.
Okay, yeah. One more question is, how would you differentiate between a desmetocele and a iris prolapse?
So desmetocele is an ulcer which is not ruptured. Okay, and the desmetocele appears like a deep hole on the cornea, with a transparent center. Okay, so Desmet's membrane is transparent. It does not take up stain. When you put fluorescein stain on these ulcers, the sides stain, whereas the center remains transparent. Okay, that's a very typical desmetocele. And in these cases, the eyeball is intact, so you can actually see the anterior chamber. Okay, so in the anterior chamber you can actually see a round pupil. Okay, so if you are looking at the ulcer, if you look deeper, you will be able to see an intact anterior chamber, and there'll be an eye, and there'll be a pupil. Whereas in a ruptured corneal ulcer with iris prolapse, you'll see like a blob on the surface, within that ulcer, and you will see a very shallow corneal ulcer with shallow anterior chamber with
Yeah.
not really a round pupil.
Yeah. Any treatment for retinal detachment?
I've seen only 3 dogs who've reattached their retinas again. And you can't really do this surgically, and especially in dogs where the retinas have detached because of inflammatory conditions. Basically, we see this with what we treated is we keep treating it for glaucoma and uveitis and systemic treatment. And even though they don't have glaucoma, we expect them to develop glaucoma, and we treat it with Dorzox T eye drops, and keep treating them with systemic treatment for whatever they've got, like tick fever most of the times, and hope for the best. But 99% of these cases, the retinas don't reattach, and most of them develop glaucoma.
Yeah. What is rose Bengal stain is used for what conditions? I mean, in diagnosing which conditions?
So rose Bengal is for corneal, some necrotic portions on the this thing. So it's rose Bengal test is useful in feline herpetic ulcers, which are very subtle, and I mean, if the fluorescein stain doesn't stain it, then the rose Bengal will. Okay, so it basically sticks to the necrotic portion.
Yeah. Are there any bandage contact lenses available for dogs and cats?
Sorry, my battery is running low. Yes, there are bandage contact lenses available for dogs and cats. And Vision, which is a German company that we buy our contact lenses, they produce specific lenses for specific type of breeds, specific cats, even horses. And bandage contact lenses are a great way of treating the superficial corneal ulcers. I wouldn't really treat deeper ulcers with bandage contact lenses.
Yeah. That's it, I guess, ma'am. Most of the questions
So thank you so much, Dr. Kasturi. It was, really informative lecture, and I'm sure, in future also, you would give us your time and we can have more sessions like these. So thank you so much. I would also like to thank Dr. Ritika, Mr. Piyush Desai, all the PPM members, all the participants, especially students. Huge number of participants are there for this session. So thank you so much, and be safe, everybody. Yeah. Thank you.
Thank you. Bye.